first of all, I thank TransplantChild for this incredible opportunity to talk about this very emerging topic, and I'm really honored to represent my institution, which is the University Hospital of Padova and the University of Padova, which is working towards at least the research part of this issue, which is important in adults, but of course must be addressed also in the pediatric population. I do not have any disclosures. I want to start from a sentence, which is the sentence of Professor Norman Shumway, who is the father of heart transplantation. And he was used to say that at least many years ago, that xenotransplantation is the future of transplantation, and it will always be like this. And even if this affirmation would have been true until 3 years ago, I would say today that in 2025 we have the instrumentations to say that xenotransplantation probably will be really an alternative to current therapies in the next years. But we have the means nowadays to say that xenotransplantation is still not the future, but it's the near future which will concretize. Xenotransplantation, which is the cross-species transplantation, the transplantation of a different species organ into a human being, is something which historically starts from ancientry. You can see that the Sphinx, as well as the myth of Daedalus, is something which has led humans since the beginning to think about the possibility of creating chimera in which the human had pieces of other animals. But of course, to translate this historical aspect into the clinical practice and the clinical research, we have to wait the 20th century. And the first representation of the positioning of xenotissues into a human being is 95, when Prince Sauteau in France inserted slices of rabbit kidney into a nephrotomy in a child with renal insufficiency, and he stayed alive for 60 days. But what is interesting is that the first experimentation was performed in a child. And this aspect, at least in the history of xenotransplantation, will come out again in the next slide. Unfortunately, the first experience in the kidney and then in the 60s in heart transplant, xenotransplantation, were not so successful. In the United States, they performed the first chimpanzees to human renal electrotransplants, 6 cases, and they of heart xenotransplantation with chimpanzee donor was unsuccessful. The first real experience, and I would say successful xenotransplantation with a heart in humans, was performed in the United States in 1985 with the so famous baby Faye, who lived for almost 30 days after the transplantation of a baboon heart into a very young infant with a complex congenital heart disease. And this case is the representation of what today we will talk about. But what is interesting is that from 1985, we will have to wait 2022 with the so famous case of Mr. Bennett at the Baltimore Hospital, at the Maryland University Hospital, in which a genetically modified porcine to human cardiac xenotransplantation was performed. So the question is why we have to wait almost 40 years before performing again a xenotransplantation. Actually, heart xenotransplantations was performed in other countries illegally in 90s, And probably this aspect slowed down the possibility of performing this kind of transplantation many years ago. But what I think that is that between babyface case and that of the Baltimore experience, so many decades moved on, because during these 35 decades, researchers had a large stuff of things to analyze in terms of immunosuppressive regimens and in terms of genetical modifications of the animals used for xenotransplantation. The first problem in xenotransplantation is which animal we can use and we might use in humans. And against advantages and disadvantages of different animals, we can, by the end, say that pig probably is the best choice because of its rapid propagation and the possibility, at least in mini swine, of a nice size compatibility in children, as we will see. But still, some aspects represents disadvantages in terms of discordancy, the problem of retroviruses, and the large size at maturity, which limits their use to date in the pediatric population, despite recent research, which I show you later. What has incredibly changed the paradigm of xenotransplantation is the technology of CRISPR-Cas9 system, which is to date the system which can be used to genetically modify the characteristics of the pigs in terms of genes, which are specifics of pigs and which must be turned down, and the possibility of expressing in pigs human genes which otherwise would be not expressed and which might cause hyperrejection in these donor hearts once placed into human recipients. And this is the historical pathway. It is interesting because 1985 was the year of the first heart transplantation in Italy. And you can see that after 35 years, we still have a long pathway of discoveries in terms of genetically modifications, immunosuppressive therapies, which have been discovered as important for avoiding acute rejection in pig to non-human primates. And last but not least, the preservation of organs like pig hearts, which are extremely sensible to ischemia reperfusion injury with the advent of ex vivo systems. Very important, the modifications of the genes in the xenotransplantation field. You know that pigs express antigens, carbohydrate antigens, which usually are not expressed in humans and for which we have antibodies which can mediate the hyperacute rejections. And these were the first molecules which were modified, the famous triple knockout, in order to avoid rejection. And what is interesting is that in infants less than 1 year old, these antibodies are not performed because usually children are not exposed to swine meat. But through the years, researchers understood that it's not only a matter of carbohydrates, alpha-gal, but it's also a matter of human molecules and genes which are usually not expressed by pigs and had to be expressed, like molecules which mediate the complement or the coagulation pathway. Through the years, different types of pigs were tested with different gene modifications, and in parallel to these, different studies in the preclinical field tried to modify and change the immunosuppressive therapy in this aspect. And by the end, we arrived to the in vivo preclinical application of these gene-edited pigs in the 2 largest groups in the world who are involved in the heart xenotransplantation program in Munich and in Baltimore. with incredible long time survival, up to 195 days. But what is most interesting from the group of Mujahideen et al. In Baltimore is that they reached in non-human primates up to 45 days of survival with these gene-edited animals, and with the implementation of the anti-CD40 antibody therapy, which is what is so-called the co-stimulation pathway immunosuppressive regimen. What is interesting is that this article was published in 2016, and the first case after this, which can be considered the most important preclinical study before the clinical application in 2022, is almost 10 years. So this is an aspect which must be taken into account, and is the fact that this kind of research is extremely complex and extremely expensive, and this is why probably a lot of time was required to reach a clinical application. And another aspect that we will develop in a while is that of growth of xenotransplanted hearts. And this is extremely important, especially in children, because unfortunately, pigs, to reach their adulthood, can become extremely big. The hearts can develop a restrictive physiology, and if you don't modify genetically the growth hormone receptor, you won't obtain a heart which can be functional in adults and of course in children. Another point is that these animals, which you can use for xenotransplantation, must be stored before donation into specific facilities, the so-called pathogen-free facility. And this is just one of the aspects that you have to take into account to reduce, lower, or abolish the risk of zoonosis, which is an important aspect in this issue. Pig vaccinations, personal screening and vaccinations, C-section, so the early weaning from breastfeeding, and pathogen surveillance in the donor before using it for donation. So before using a organ for xenotransplantation, and this was the way in the cases performed in the United States, you have to have a similar facility before performing a donation and a transplantation. All these aspects were developed before the first clinical cases. I recommend you to read this, which was the first report of a genetically modified porcine to human cardiac xenotransplantation, in which they used a 10 gene edited pig with modifications for the enzymes which are involved in the production of these carbohydrates to reduce the graft growth, and then human expression, which were used to regulate the complement, the coagulation, and the inflammatory pathways. And in addition to this gene modification, on the right, you can see the use of ex vivo system to preserve the heart during the transportation and avoid the ischemic injury to which the pig hearts are extremely sensible. Again, this slide is just to show you the complexity of the immunosuppressive regimen for the clinical xenotransplantation, in which, in addition to conventional drugs like tacrolimus, steroids, albumin, they added medications like Berinert or KPL 404, which are medications used against complement and against the blockade cascade, drugs which are still off-label, expensive, and not used in children. And this gives you the idea of how difficult can be the implementation of such strategy. But what is interesting is that despite this complex immunosuppressive regimen and these 10 gene editing therapy, after 60 days, the patient died. The reason of death were related to an infection with the porcine cytomegalovirus and also signs of rejections. The same rejection who led to death, the second case 40 days after transplantation with the same 10 gene-edited pig. In parallel to this experience gained from the University of Maryland, in NYU in US, they performed 2 brain-dead cases in which they used 2 brain-dead recipients who led their consent for research, and the pig heart was kept alive for 66 hours. And in this case, they did not find any signs of rejection, but probably because 66 hours was too early to detect any signs of rejections after a few hours. But of course, this clinical case and this evidence in adults has led the public opinion to discuss this aspect on a public scenario. So xenotransplantation, are pigs the future of organ transplants? But what I want to talk with you today is xenotransplantation the future of organ transplantation in children? Usually when we talk about transplantation, we usually rely to guidelines. And unfortunately, to date, there are no any guidelines for xenotransplantation in adults. So you can imagine that also in children, there are no guidelines. But a few years ago in JTCVS was published this very interesting document, which is a consensus statement which was signed by different exponents of pediatric cardiac surgery and also experts of xenotransplantation worldwide. And the synthesis of this consensus statement is that probably one day will arrive to the implementation of this technology in children through 3 important steps. First, the research steps, which means understanding the safety and efficacy of an optimal genetically modified pathogen-free donor animal. Second, the importance of industry, which will be the medium to generate and create these safe and efficient animals, and who will be in charge for the regulatory issues and creating those pathogen-free facilities which are required to storage the pigs before the donation. And third, the most important part is that of the clinical translation, because we will have to better understand how to select our pediatric recipients, which might be the optimal technique for heart transfer and transplantation, the importance of immunosuppression and monitoring of this immunosuppression, the development of tolerance, and the aspect of retransplantation. And all these 3 steps are underneath by ethical considerations which must be addressed early in advance before the clinical application of such technology. The biggest challenge in pediatric xenotransplantations are foremost represented by, of course, the problem of interspecies disease transmissions, the concept of zoonosis, and the risk of spreading infections which might harm the population health. But these aspects is just one of the open issues, because of course we have some research ethics problems of informed consent and long-term research obligations which are mandatory, and that, and last but not least, the problem of allocations to whom we might consider this strategy, the costs of the technology, which is expensive for research, but also for clinical implementation. And this aspect of costs is in contrast with the concept of equitable access and distributive justice concerns. 1 year ago in JAMA Pediatrics, Daniel Hurst and Luz Padilla published this very short but strong 5 point on the ethically advancing of pediatric cardiac xenotransplantation. And these two authors point out that to think to the clinical translation of this technology in the pediatric population, we have to answer to 3 questions, which is when to start pediatric trials, who should go first, and third, the aspects of informed consent. So the first question is when we can start pediatric trials. We can answer to this question considering the cons and the pros of xenotransplantation, because of course, in 1996, the only ethics guidelines on xenotransplantation was used to say that it would be difficult to justify the involvement of children in major and risky trials as recipients of heart xenografts, for example, before some of the uncertainties have been eliminated in trials involving adults. And this is correct, because usually we are used to perform this kind of trials in adults before children. But what probably many of you do not know is that at least on an immunological standpoint, xenotransplantation has, of course, might have big advantages in the pediatric population. First, because the pediatric complement and regulatory cascades are decreased in this population. As said before, anticarbohydrate antibodies are not performed in infants, and consequently, their immunological reactivity might be lower compared to adults. Besides, pediatric patients have reduced innate cell activity. Third, most of pediatric patients with congenital heart disease undergo thymectomy during the first months of life during their cardiac surgeries. And thymectomy is associated with decreased T-cell response. Consequently, this might be an aspect which can be added to the advantages of xenotransplantation. Infant cardiac grafts show longer survival than adults, and unfortunately, infants at the same time have worse outcomes and more scarce therapeutic options. And this point probably unbalanced the balance towards the advantages of thinking to xenotransplantation in contrast to what the old ethics guidelines was saying. This rapid fire is just to show you how in the first year of lives, children do not express antibodies against the antigens of red blood cells, not only in the triple knockout, but also in the wild type pig. And if we take Norwood infants who underwent the Norwood operation in the first month of life, you see that their immunization against pig genes, especially for those patients in which pig tissue was implanted for the reconstruction, for example, of the aortic arch or other part of the heart, you can see that they do not develop any immune reaction or antibodies against the pig genes. Who should go first? This is a very complex question. We might consider, according to current statements, that probably patients for whom heart transplant is ideal, but allotransplantation would be unlikely, might be considered like highly sensitized, early graft dysfunction after allotransplant, severe cardiac failure, and poor candidates for mechanical circulatory support, or again, patients with failed second stage single ventricles, failed third stage single ventricles, complex failed biventricular CHD, or dilated restrictive cardiomyopathies. But the point is that probably we are still not ready to say which is the best patient, but we can only say if xenotransplantation might be considered and reasonable according to the current evidence. And the current evidence is that if we take the Eurotransplant zone, you can see how in the last years the number of patients, pediatric patients requiring a heart transplant has progressively increased, but unfortunately compared to adults rates, the mortality during the wait list for heart transplantation is still high. In Europe, we reach 20-30% of pediatric cardiac wait list mortality, which has slowly improved towards the years. This is a little bit lower in US according to the centers, from 5 to 30%. And you can see how younger age at listing and complex congenital heart disease represent a risk factor for mortality and the listing because of clinical deterioration. And 25 of infants less than 12 months in the US die waiting for a heart, which is a very incredible number compared to adults' number. On the other side, we can say that if a patient arrived even in the first year of life to get a heart transplant, the survival rates are extremely favorable, reaching almost more than 50% of survival after 20 years of transplant, according to the IASSLT registry data. And if we take a look at these data from the same group who performed the baby-fake xenotransplantation in 1985, you see how low is the 30-day mortality in primary transplant for congenital heart disease. Essentially, we are talking about patients with univentricular physiologies who underwent heart transplantation during the first month of life, and how high is the survival at 20 years, better than adult recipients. Of course, the problem is that of donor availability at this age. But if we compare those data to the data of the only trial on HLHS, this was a trial on the Norwood operation comparing two types of shunt during the operation, you see, I put this just to show you the survival rates at 12 years, which is really lower compared to the survival rates showed for heart transplantation. You see that we reached, for a few points, the 50%. But what is extremely sad is that if we take the population from this trial, we have that the amount of patients who died and were never listed from this cohort is almost 30%, with a waitlist mortality of almost 40%. And of the small amount of patients from that cohort who underwent heart transplantation after a Norwood operation, you will see the poor outcomes at 1 year after transplantation, which is far from the outcomes that we had if a primary heart transplantation was performed. Again, if we compare surgical palliation to primary transplant, you see how different are the curves at 16 years after transplantation or palliation. But you will ask me, okay, very nice data, but where can we find these donors? That's the point. If we take into account the mechanical support in children, and we take the data from the PediMax registry, which is the most important registry of mechanical assist device in children, you see how congenital heart disease patients, the red line, have very worse outcomes at 1 year after implantation compared to patient with a cardiomyopathy. But again, this report, which is very early, which is very one of the most recent, again, you have data at 12 months with a poor prognosis for congenital heart disease patient. This aspect of mortality should be added to the aspect of morbidity. a 30% of stroke rate, 25% of risk of life-threatening bleed, costs of prolonged hospitalization, exit site infections, all aspects that should be added to the concept of the longer waitlist time and mortality for patients waiting for heart transplant. And so if these are the data to date, probably xenotransplantation should start to be considered for at least for a bridge to allotransplantation, or some people say to a second xenotransplantation. And this is a recent study which, at least in an in vivo preclinical scenario with smaller non-human primates and smaller pigs, you see the weight which is smaller compared to the weight, the pig weights which was used in the previous research context, you will see how excellent, or at least promising, are these data, with one of these baboons reaching a survival of almost 1 year. Of course, the numbers are very slow, are very small, but of course, these are very promising data, at least for the pediatric population. Third, the aspect of the informed consent. Of course, informed consent for xenotransplantation in children does not mean informed consent in adults, but you need to involve parents or guardians, and unfortunately, no current trials on how to counsel surrogate decision makers. Again, the problem of xenozoonosis, the need for chronic monitoring, in which you don't have an established follow-up, and of course, the uncertainty of long-term outcomes, the psychosocial issues, and the risk of stigmatization. This is a very important aspect. When you talk about allotransplantation from the pediatric to adulthood, one of the aspects which is usually discussed in Congress is that of the transition. It is not only a problem of transition from pediatric to adult in the field of congenital heart disease, but it's also a very big issue in transplantology. And this aspect must be ruled out when you do an informed, you might consider an informed consent for xenotransplantation. The problem of growth, as I said before, these hearts, even if you modify genetically the growth hormone receptor, can become restrictive. And so the question is, how can we avoid this problem in the pediatric population? Of course, the gene editing, which is already performed. Some researchers highlight the importance of using smaller pigs like Yucatan pigs or Auckland Highland pigs. And third, there are some pieces of literature which demonstrate that probably rapamycin as part of the immunosuppressive regimen might get a less rapid growth of the graft. Another problem is that of logistics, because in adult cases, the ischemia minimization was obtained by using this ex vivo hypothermic perfusion machine, which to date is still not is that probably creating an operating room which is close to the operating room of the recipient might reduce the time of cold ischemia of the pig donor heart. But of course, we are still far away from this possibility, because we might have hospitals which have specific rules to manage both humans and pig in pathogen-free conditions. And again, the problem of the infective risk in the recipient. Vaccinations, preventions, for which no standardized protocols are still not available. The importance of a strict surveillance in the recipient by means of PCR studies which evaluate the presence of the retroviruses, the cytomegalovirus, the circovirus, and the serologies, and the problem of logistics, single room, disposable, contact precautions, gloves, and so other things. Another important aspect to consider towards the program, towards a xenotransplantation program, is that of public opinion. Population should be informed. We live in a world of animal rights, and of course, this must be respected. And there are also some religion aspects and costs aspects which might make it complex to start a similar program. But another aspect is that of the healthcare personnel. I advise you to download and read this very interesting survey on the attitudes to cardiac xenotransplantation by pediatric heart surgeons and physicians, in which it was asked to these two categories to evaluate their attitude towards a cardiac xenotransplantation program. And what is extremely sad is that less than 50% of congenital heart surgeons and pediatric cardiologists would have been favorable towards heart xenotransplantation programs, even if with worse outcomes in xenotransplantation as a bridge until a human donor heart become available. And this aspect must make us in the condition of understanding that probably physicians and health personnel should be the first to be trained to understand what cardiac xenotransplantation is and how it can be implemented. So to reaching the end of my presentation, which might be the strategy for achieving a success for long-term cardiac xenograft survival in adults, but especially in the children population? First, we have to understand how to, which are the genes which are necessary, sufficient, and necessary to avoid acute rejection in the pediatric population, remembering which is the peculiarity of children and infants in terms of immunology. Second, we have to preserve the heart of the donor, considering its problem with ischemia, injury reperfusion, and the implementation of ex vivo perfusion systems also in the pediatric population. The importance of immunosuppression. The immunosuppressive regimens used to date are expensive, are off-label, and not used in children, and probably regulatory agencies should start to consider that without these drugs, we cannot perform this kind of transplantations, and we have to start to think about trials on these medications. And fourth, the importance of a specialized team, which does not mean only personnel which is informed and formed to this approaching technology, but also having facilities and hospitals which are ready to accept this kind of technology. So in conclusion, just to make a summary of this complex topic, I think that the improvement of preclinical research in terms of immunosuppressive therapy and pig gene editing, it's important to obtain a more immune tolerant graft, which does not mean only gene editing, but means only the bioengineering of the pigs in terms of molecules to reduce the endothelial damage. Second, the importance of consider infants with complex congenital heart disease as patients who have a higher waitlist mortality and worse outcomes in bed, and probably would be the first to be considered as best recipient for xenotransplantation. Xenotransplantation to date cannot be a destination therapy, but probably in the pediatric population might be a bridge until the child become bigger and higher, and so can accept a bigger heart. The importance of informed consent, and last but not least, the matters of public health in terms of religion, of costs, of public opinion and of zoonosis and microbiological conditions, also according to what happens a few years ago with the COVID pandemic. I really thank you for the attention. This is just a photo I took a few years ago when I visited the Baltimore group at the Maryland University. And I hope you enjoyed this presentation, and I'm here to answer to your questions if you have any of them. Thank you.